we are going to talk about teaching. Teaching how to teach. Let's teach how to teach in postgraduate medical training. And I am now from San Francisco, which is a lovely city on the West Coast, and hopefully many of you can come to visit. And if you listen to my accent, you said, he does not sound American. And the fact is that I'm actually German by background. Went to medical school in Germany, I did my residency in Germany, and then 20 years ago went to America. So, any Germans in the room? No? So, you might have noticed that my people sometimes have an accent.
Das hier ist mein Sektor. Das hier ist das wichtigste Gerät des Küstenwächters. Das Gerät und das Gerät. Überlebensradar.
Mayday. Hello, can you hear us? Can you hear us? Can you... Over. We are sinking. We are sinking.
Hello? This is the German Coast Guard.
We are sinking. We're sinking.
What are you thinking about?
So let's see what we're going to think about, shall we? Let's think about how to teach. Again, how you have to ask basically, if you're standing here and there are people over there, what is the goal of your lecture? And how many of you are teaching graduate students? So they teach medical students, nursing students, somebody who has to pass a test next week or something like this. All right. So the goal for them is probably very different. And how many of you are teaching clinicians, nurses, residents, doctors, psychologists later on? So many of you do both. Some just do one or the other. And of course, the goal is very different, right? For a graduate student, medical students who are sitting here, and you have to give them 1 hour lecture on embryology, it's maybe not very exciting. And all they need to know is like enough stuff to pass their exam. Many of them will not become that. So that might be very different. I will concentrate mostly on the second part. I'm going to concentrate on those of you who are teaching young doctors, senior colleagues, so teaching psychologists or social workers. And the idea is actually you want to change their behavior. You want them to do something different tomorrow or next week. But even those of you who are teaching medical students, nursing students, I would try to invite you to use interactive modalities, something which keeps them awake and keeps them actually interested in the topic at hand. So let's talk about different modalities of teaching. And we're going to talk about the interactive lecture, something what I'm doing right now, hopefully. At the moment I'm speaking, that's not very interactive, but you shall see what this is coming from. We're going to use a case example. When can we use cases of a real patient or a made-up patient or person in our teaching? And we're going to do some role play. Ooh, that's going to be exciting. And then mostly we're going to concentrate, because in this room you will mostly do interactive lectures. So we will talk about the one thing. What is the hook, the tension point? How can we address attitudes, barriers, myths, obstacles? Why do people not do tomorrow what I want them to do? And then we talk about the knowledge piece and how to do this well. And we finally will talk about the skill. So just think of a very ineffective medical lecture you attended. Just think back, close your eyes for a second or two, or even watch this. Think of the worst lecture you had in the last few years. What went wrong there? And once you have this idea, just talk to your neighbor, for a second or two and tell them like what really went, like when you think about those very ineffective lecture. So as you see the secret video here from physiology, and people in a coma, asleep. Look at the amazing slides, so well done, Okay, talk to your neighbor for 30 seconds and give like 1 or 2 examples of why this went not well. Great. Shout out. Give me some examples. What went wrong? Think of your most boring lecture ever. What went wrong? Too much text, right? 723 PowerPoint slides in small text, like far too much text. Great. Yeah. Love it. What else? Monotonous. The person was talking in the same speed all the time, is leading from the slides, is standing behind the podium, is all like this, and for the next 60 minutes, this is what you're going to hear, right? Something like that. It's really falling asleep, right? That's the time when you check your emails. What else?
No interaction.
No interaction. Yeah, people are basically in behind, in there leading this, and then you go for the next 60 minutes. So, yeah, it really doesn't connect. What else? Okay, let's do. So, how many of you going to use a PowerPoint or keynote presentation within the next 12 months for teaching? How many are going to use a PowerPoint presentation? Okay, let's see. Yeah, actually, we can do this. Let's quickly do bad presenter bingo, yeah? So think of your last lecture. Who gets the first bingo? 5 in a row. Anyone? 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 A joker? Anyone? 5? My favorite is, I know this slide is a little busy. Okay, let's talk about PowerPoint.
There's some things I hate about PowerPoint, and I figure it's my duty to point them out. So here we go. Here's common PowerPoint mistakes. Number 1, people tend to put every word they are going to say on their PowerPoint slides. Although this eliminates the need to memorize your talk, ultimately this makes your slides crowded, wordy, and boring. You will lose your audience's attention before you even reach the bottom of your first slide. Please don't do that anymore, please. And number 2, most common. Now, many people do not run spell check. Big mistake. Nothing makes you look stupider than spelling errors. If it's got a red line under it, recheck the spelling. And then finally, I hate this. Avoid excessive bullet pointing, only bullet key points. Too many bullet points, and your key messages will not stand out. In fact, the term bullet point comes from people firing guns at annoying presenters. Hence the bullet point. Color schemes, not good. Clashing background and font colors can lead to distraction, confusion, headache, nausea, vomiting, and loss of bladder control. I can't stay on that one too long. Here's something I've noticed. The number of PowerPoint slides you have in your talk, the less useful your talk actually is. Unfortunately, my presentation is right there. I've also noticed this. People love to pack data into their presentations. They shove more and more data thinking it's better, but it's not. The more data you have, the harder it is to read your slide, and the effectiveness plummets. Now you can improve the effectiveness by adding some shading and some 3D effects, and then some second order and third order effects, and then, I know, let's add some labels. That'll help a lot. And that's pretty much every marketing slide I've ever seen right there. Yeah. Then some like VP of marketing standing there going, it's real clear in Q4. What the hell are you talking about? Now, I'm into in animation. People become animators in PowerPoint. You can have things flying all over the place, and that can be good. If you're a visual learner, that will improve the effectiveness of your performance. But if you're easily distracted, more animations, and people have no idea what you're talking about. They're just, wow, that is cool, wow. And there's regions here, by the way. There's the simple but effective region. There's the active but confusing, the effective but boring, the active but ineffective, the dull but static region, the busy but useless, the ADD only region, the useful but amusing, the stupid but confusing, the dull triangle, the hyper triangle, the sleepy square, the dizzying pentagon, and everything else I just call pointless motion. That slide right there took me an hour and a half to make, right there. PowerPoint can just suck the life out of you. It's amazing.
PowerPoint just sucks the life out of you, doesn't it? The problem is, in medical education, that we assume if I just give you enough knowledge, you're going to change your behavior later on. So as a clinician, I'm a pain specialist, right? I want you to put numbing cream on a child before you put in a needle. Before you put a needle, a vaccination into a child, please put numbing cream on. I can give you 70 slides and give you this information. No one of you is going to do this tomorrow. So how do we do this differently? So this idea, we just shove more and more slides, and that was the first thing coming up of bad lectures. This is not going to change behavior. If our goal is to change behavior. Sometimes we teach people for their test, right? They have to pass their exam, and then at least we want to make it really interesting. So how's this? This is all I'm going to talk about the next hour. Yeah? This is useless. It's a terrible example of far too much information, too many colors, useless slides. Nothing of this is going to change your behavior, not going to do anything. You're not going to do your teaching differently after this. So what we have learned is, if you want to connect to your students, to your residents, or there may be people, yeah, the dean is here, like much more senior people like me. So you basically want to connect to people, and if you want to change behavior or provide some information, you provide a hook. We're going to talk about this. Why would they not do it? Why is the change you want to do? Find out what's the barrier, what's the obstacle, what's the myth, what stops them from doing. There are actually seats here. You're very welcome to them. I promise I have showered. Yeah, and those of you who sit up there, that means you're volunteering for a role play. That's great. Yeah, so everyone is on the stairs who's not sitting up here can do a role play with me in 5 minutes. We're going to talk about the knowledge piece. This is what we're good at. We're really good in putting knowledge, information in our PowerPoint slides, but often it's too much. And then if I want people to take something home, if I want people to learn something, then we want to teach a skill. So we're going to practice that. And that increases the chance that my colleagues from pulmonology will be comfortable to give a dose of morphine for a child who's breathless. That will increase the chance that my colleagues might be interested to give methadone to a child in end of life, if they'll have to learn a skill. Just the slides are not going to do that. All right, so in your handouts, and I will give you the QR code, you have a cheat sheet. So if you're thinking tomorrow you have to do a presentation, you can go through this 1, 2, 3, 4, 5. So let's go through this. Yeah, if you want to change the behavior. The one thing is basically, what is the one thing you want to teach today? Before you start making your very first slide, you're invited to give a lecture, you're giving a presentation. Think about, what's the one thing I want to do people differently? And then you write this down and say, okay, that's the one thing I want them to do. I want doctors to put numbing cream on a baby before they vaccinate. Maybe that's the one thing I want to do in my presentation. So then I will plan everything else around this. I want people to feel comfortable to use a certain sentence in a difficult conversation. That's my one thing. So you think about what is the one thing in your presentation. And then everything else falls around this. Always, it's really hard to be clear and concise. And then you talk about this at the beginning. Thank you so much, dear pediatricians that you're here. I'm going to talk about the importance of numbing cream for vaccinations. And then I go to the middle part, and I show all the data of the presentation, and let me now show you how we're going to put numbing cream, EMLA cream, or lidocaine cream on babies. At the end, thank you so much for listening. I hope I could convince you that putting numbing cream on babies is a good idea. Right? One thing at the beginning, one thing at the middle, I'm talking about this, and one thing at the end. If that's the one thing, I want people to do it differently. So you do your introduction, you have your body in the summary, and you will get all my slides in a bit. So you will have, if you have any trouble falling asleep tonight, you're very welcome to go through them in detail. All right, so let's start with an interactive lecture. Interactive lecture means, okay, I'm teaching something, I want to be interactive, and I have 5 seconds where you decide whether you're going to listen to me or whether you're going to work on your emails. And one thing is just, it's like you want to be lively, right? I said, good morning, lovely people. Yeah, that's interesting. Let's listen for 10 more seconds. Give him a chance. Yeah, so starting with nice, gentle, looking at the people. You see me walking around with the microphone. I'm looking at this, right? I already know you're the three who do role play with me in a minute, right? Because you don't want to sit in the first row, or you can sit here. No pressure. So you're working around. Yeah, I've already asked questions, right? But you want a hook, a tension point. A hook means at the very beginning of your presentation, you want some people that, oh my God, I want to listen to this. This is really good. Something emotional. Maybe you talk about a case which was difficult, or maybe you talk about something which makes people convert about this. We talked about bad presentations at the beginning, so this might be a hook. So I'm now giving you, I'm a pediatrician, I'm a pediatric pain specialist, I'm a pediatric palliative care specialist. I'm usually not invited to teach how to teach. I'm usually invited to talk about stuff. Yeah, currently I'm here in Prague managing a 5-day conference, and one talk I gave yesterday was about needle pain. Okay, so I will now give you a part of my presentation. You ready? Good morning, lovely people. So I just visited Prague for the very first time here. If I go and to every single doctor's office in Prague, and I ask every single child, what are you most afraid of seeing this doctor right now? What is every single child going to answer? It's the needles. It's the pokes, right? So we published this in the Journal of Things We Already Know. Babies and children really hate needles. And so do their parents. Because when they come to us, this is what they see. This is what they get. Healthy children will have 16, 17, 18 vaccinations in the first 2 years of their life. And if children get sick, how many of you are pediatric clinicians? How many are pediatricians or something like this who sees children? Yeah. Once they come to us, we draw blood, right? We have to do injections. They need intravenous access. So this is what's happening. This also happens to adults who hate needles, or for that matter as well. So let me show you a video. A few years ago, I was asked to speak in Copenhagen to the Nordic Anesthesia Society, and they showed this video. This is in Danish. It's a 1-minute video. How many of you do not speak Danish? Danish? No? Okay. All right. So even if you do not understand Danish, I'm going to ask you what went wrong here. Because this is a nice 5-year-old boy by the name of Marius. Marius fell off a bicycle. He needs some stitches. Lovely nurse, a really cooperative child. He's going to get some stickers. And then something goes wrong. So I'm going to ask you in 60 seconds, what do you think went wrong here?
Slå din finger, sæt du ham op her. Han har fået revet det yderste stykke af fingeren af, og det hænger meget løst. Hvad var der sket? Lidt. Nu pakker jeg den op forsigtigt her. Så kommer Miki.
Er du kommet til skade med fingeren?
Jeg pakker fingeren ud af forbindingen. Kan jeg se, at det er det vi gør, når vi skal bedøve fingeren, sådan så at det ikke kommer til at gøre ondt, når vi skal rense og sy. Og berolige drengen hele vejen. Vi holder hånden der. Sådan en 5-årig dreng kan godt være rigtig stærk, så vi er nødt til at hente noget forstærkning, som simpelthen kan holde ham fast. Både at bedøve fingeren, og vi er ikke nogle flere kollegaer, og så er vi 5 voksne mennesker, der er nødt til at holde hans lille arm, for at vi kan få det.
Should we quickly count how many adults are holding down this 5-year-old boy for the elective procedure? 5. We're not saving lives here. This is bad medicine. This is terrible. This is unethical. And it happens in children's hospitals all over the world, including my own. Because we were trained that way. Or you just have to hold them down, you have to do this fast. And we really have to do this, and now we know this is absolutely terrible. Yet, we're doing this. We're holding down children for vaccinations, we're holding down children for stitches, although we know we can do it much better. And I'm teaching this all over the world. We have now rolled this out and changed this in many countries. And often here, Dr. Friedrichsdorf, we just don't have enough staff for pain control for children. It's amazing. We always tend to have enough staff to hold on children. This is not pediatric analgesia. This is unethical. This is terrible, bad medicine, because we have not changed yet. All right, what is my hook? A hook is to create an emotional response in you so that you are interested in listening to the rest of my lecture about the knowledge piece. And both for my teaching piece as well as now for my needle pain piece, I used certain hooks. What did you notice? What was my hook, my tension point? What did I do to invoke an emotional response?
You asked a question.
I asked a question. Great. Tell me more. What question?
What do you think is the most scary thing for a pediatric patient?
I asked the question, what was the worst thing for children? That is something, oh, that's true. Actually, I don't like needles either. Or I have a child, or maybe have been a child. Yeah, so this is something where it's in there. So asking questions is one way. What else did I do for a hook?
Invoke the emotion of unfairness towards children, unethical treatment, or restraining the child down for...
Say again, this was excellent. Say again, yeah.
You evoke the emotion that it's unethical what we do to children, to restrain them for just simple injections or so on, and that we have better ways of doing it that is not unethical.
So that's the tension point, and you're also probably saying, so what are the better ways? So I'm probably going to stay, hopefully, for my second part of the lecture when I'm going to tell you what to do differently. And so this, what else did I do? What other hooks did I have presented so far? Interesting, we say, oh, that's different. I'm going to listen. I'm not going to work on my phone. I'm actually going to listen to this guy from San Francisco.
You told a story. You told a story.
Tell me more. What story?
I felt like I'm there with you all over the world. You talking about this interaction with staff all over the world with this topic. I just felt that I was there with you. You told a story.
So that is exactly right. Yeah. And styles are very different, right? All of you, I'm very extrovert, right? I'm walking around with a microphone, right? I can do this. Not every one of you will feel comfortable with this. And it's completely fine to be quiet and introvert and not running around. You can still give an amazing presentation. You want to think, however, what's the hook? What's the emotional thing, right? What is basically something you can do? You can do a needs assessment. So you can say, okay, we are going to talk for the next hour on pain. What interests you? What do you want to make sure that I'm covering in the next 60 minutes? And then your people answer, right? And then you see, this is what they're most interested in. So I write this on the board, on the flip chart, and I can come back to this. So using a needs assessment could be something. I'm going to show you a video. Yeah, and I've used videos, yeah, so I think they're very effective. You can use a trigger video, something which, yeah, so you've seen a child being held down, and I will come back to this. That's a trigger video, triggers you. You can present amazing data. If you work within like an institution, in your department, in your division, there might be a difficult case. There might be something everyone knows, and you want to do this. Other ideas? Any other? Many of you have been teaching and are good teachers. What else do you use as a hook, as a tension point, something to grab the attention of your audience right away?
For me, it actually worked like examining the stance. You presented an opinion, and you presented an opinion that was very strong and univocal, which is rare in our roles, which is always, it's a little bit like that, it's a little bit like this. But you hooked me by saying, I think it's like that. And now we are going to have to talk about that presents a hook, basically.
Yeah. So making a statement, thank you, can be a hook. And again, I'm not Moses coming down with the 10 Commandments. I may be wrong. Yeah, I'm an ex-medical student. What do I know? So meaning it's possible, but I'm going to present some data in the knowledge piece.
Yeah, sorry. quick comment. It hooks because you can either strongly agree or strongly disagree. And that's the reason.
Yeah. You might be in the room, I think it's fine. It builds character. I think we should hold children down and put needles into them. And yeah, and we can talk. All right. So my one thing in the teaching lecture here is have a one thing. My one thing in the needle poke presentation is put numbing cream on children and do not hold them down. Okay? So you see what I'm doing. I'm giving a presentation within a presentation and then teach you how I do my presentation within the presentation. Make sense? For needle procedures, always offer numbing cream and never hold a child down. That's the one thing I want you to take home out of my medical lecture today. So that's what was my one thing. I started with a hook. Why would you not do this? So I'm in the Czech Republic. There are hundreds of thousands of children within the next month who are going to get a needle. Why would they not all get numbing cream? So if I want to change your behavior, so I'm not teaching medical students or nursing students for their next test. That's also fine. Then we use all this, but you do it a little bit differently. I need to ask myself, why would you not do it? What stops you doing it? I need to find out why this would not happening in your hospital. All right, so I'd like you to make sure, please, when I'm flying back to San Francisco on Saturday, so next Monday, I want that for all Czech children, all the time, everywhere, and not just for some children, some of the time, who have a lab draw, a blood draw, an injection, an IV cannulation. So if you can please make sure that they all have numbing cream, EMLA, 60 minutes before. You always offer sugar water or breastfeeding for babies. You never hold them down. You always offer comfort position, and you always use age-appropriate distraction. Okay, can you do this next Monday? All children in Czech? Great. What might you hear from your colleagues or from parents why this is not going to work next Monday in the Czech Republic for all children all the time? Time. Would love to do this, but there's just no, who said this? Yeah? Would love to do this, there's no time. I'm a really important doctor. I cannot wait for the bloody numbing cream to be on the child. I need to do this now. So that's the number one thing, the time. Because we have to get the numbing cream on the child 60 minutes before. Are the parents doing this at home? Yeah? Are they doing this at check-in? Do we round on the patients and then say, okay, this patient needs a blood draw. I come back in 60 minutes. Let's put the number. So we have to change how we're working. I'm here with the patient now, I need to do it now, then it's too late. So that's the number one thing we're going to hear. Not going to happen next Monday because of time. Thank you. What else?
Change of habit.
Change of habit. We've always done this. I've done this for 27 years. I'm holding them down. You do it fast, right? That's the best way. This is how I was trained. Yeah. So changing habits would be another thing. Thank you, sir. What else?
It's not a big deal.
It's not a big deal, really, dude. Yeah, I mean, it's one needle, it's 1 second. It's not a big problem. It's either. So we find that children actually become needle phobic and then they don't get vaccinated. I've taken care of 5 children who died of measles because they were not vaccinated. We find people who forgo medical care because they're afraid of needles. Yeah, but people say it's not a big deal. Yeah. What else might you hear?
This is how we've always done it.
This is how we always done it. And we turned out well, didn't we? Yeah. So, yeah. And if we want to, yeah, and I asked my own staff when at the time I was at Children's Minnesota, one of the largest children's hospitals in the United States, and I asked our staff, nurses, doctors, social workers, how well are we doing? And the results were encouraging. They actually told us we're doing great. On a scale of 0 to 10, with 10 being the most awesome, my colleagues told me we're 9 out of 10 in preventing pain caused by needles. However, that level of enthusiasm was not shared at all by the patients. So when I did a survey, we actually asked all kids, how was your pain experience within the last 24 hours? They actually said we were terrible. The number one thing we were worst at was needle procedures. The rest actually was all right. Cancer pain, post-surgical pain, so that actually was mostly under control. the needle pain was the #1 problem because it was everybody's problem, but nobody's responsibility. And the idea was basically, people thought because we're offering to some children some of the time, we're doing a great job. When we started measuring it, it's only 10 to 20% of the children got numbing cream. 80 to 90% of the children did not receive numbing cream and they were even held down. So we had to change culture because it doesn't hurt that much or there's nothing we can do. Yeah? Hold them down and do it quick. Yeah? Or just get it the first time is basically what we heard. So let's ask Charlotte. So for painful procedures, isn't the best just to hold you down and do it quick? So she seems pretty convinced that holding her down and putting a needle into her without numbing cream is not the correct way. So we have to change culture. And we rolled this out. My children's hospital became the first hospital in the world to do this for every child, every time. And since then, it has been rolled out in 50 other children's hospitals all over the world. Again, if you have trouble falling asleep tonight, this is the article, how we did this, and it's also in your box. All right. Stepping out, I'm teaching how to teach. I want you to do one thing differently, and I want you to find out what stops you from doing this. What did I do to find out what might be the barriers, what might be the obstacles, what might be the myths of doing what I want you to do? How did I find this out from you?
You asked.
I asked. Yeah. It's a novel concept. You actually ask your audience, right? And not only did I ask, you also answered. And I'm trained in palliative care. I'm great with silence. So I'm fine asking a question. If there's no answer, I just stand here. After 10 seconds, this becomes so uncomfortable, somebody is going to say something. Yeah. So I ask you, but did I tell you, why are you not doing this? Why are you such a terrible person? Why are you putting not numbing cream on children? I didn't ask that. How did I phrase the question? Do you remember?
Presented the extreme case and then the extreme situation and then ask why people would not do it.
Say again, amazing.
You presented the extreme case of everyone following your recommendation and then ask why people would not do it.
So the evil trick here was, I did not ask you why are you not doing it. I asked why would your colleagues not do it, or the parents, right? You never, ever, because that's too confrontational, right? If I basically said, what, you're not doing this? What a terrible person are you? Yeah, you never do this. Like, why would your colleagues not do this? What do you think they would say? And then people can say what they think themselves, or what actually says that. So I ask you why your colleagues think this may not happen for all children all the time in the Czech Republic, starting on Monday. And then I got 5 answers. What did I do with those answers?
Paraphrase them.
I did paraphrase them. I'm getting my exercise in here.
You paraphrase them and expand on them.
So I paraphrased them. Yeah, I basically said them again, like, did I get you right? So what you're saying is the following. And as fighting with your mother-in-law, right, the single most important thing is they want to be heard. So what I hear you saying is the following. Do I get this right? And then I expanded on this. I already gave you some sort of knowledge piece. Time, great thing. And we have actually modulated this. We found that it actually goes faster. With putting the numbing cream on, we actually can see more children per hour. And when do I present this data? In the knowledge piece, now when I'm coming. But if I want you to not hold children down and put numbing cream in, I need to find out why would you not do it. And maybe somebody says we don't have numbing cream, or it's hidden in the dean's office right under the chair next to the leopard. Yeah, there might be something I'm not, so we have to find out what would be the problem. Why would we have to change this? So why would your colleagues not do it? You can have a group discussion. At the beginning, I asked you to a bus group. Bus group is like 2 or 3 of you to talk about this, right? Think about a back lecture. That's a hook. Yeah, that's also, you can get some information out of this. I can basically also then say, if they say it's too much time, let's spend 5 minutes in groups of 2 or 3 and talk about what would you say against that? And then go back, okay, who has got a good idea? So I can keep this interactive, working on the attitudes, working on the knowledge piece. Questions so far? I haven't even started with the knowledge. Medical lectures usually only do knowledge. And I'm already 35 minutes in, and I haven't done any knowledge. So any questions about the one thing, the hook, attitude? Comments, concerns? You see, I'm palliative trained. Silence. And then we go into the knowledge piece. So I'm now going to, for the next 15 minutes, going to present some knowledge. And afterwards, I'm going to ask you, how did I present that? Yeah? Because now, in the knowledge piece, you want to address the barriers, the obstacles, the myths. So what you said about children, the numbing cream, the time, right, we don't, yeah, so I will come back to this and will present this, and either I have the slides ready for this, because I anticipated that, or I have to basically then, I write this down and then come back to this in a moment. All right, so I have knowledge piece, I have 75 slides to discuss in 10 minutes. Save your questions to the end, please. Sit down and never talk to me again as long as you live. Yeah. How did the CE presentation go? It was 72 slides, 75 slides too long. So take-home message is we need to be really, really careful. So I'm going to talk about the comfort promise, something we started 2013 at Children's Minnesota, and since then has been rolled out in more than 50 children's hospitals in 30 countries all over the world. Thank you. We talked about the comfort promise means for every child, every time, when we put a needle into them, we're going to offer some numbing cream. We use comfort positioning, we use age-appropriate distraction, and allow patients and parents some control. And for babies, we do sucrose or breastfeeding. And for older children, we help them to change their memory. This was great. Do you remember how well you did? So we're going to talk about that.
There are numbing agents available that can really help with needle pain. Why wouldn't we use them? Critical care areas may have J-tips that are easy to use, work immediately, and last around 20 minutes.
4% lidocaine cream is available everywhere, even without a prescription. It needs about 30 minutes to work, so you have to plan ahead. It lasts for about 1 hour. You can cover it up with Tegaderm or cling wrap so kids don't get it in their eyes or mouth. But it's worth the time and effort, believe me.
That's for sure. EMLA is a mix of lidocaine and prilocaine, and it needs a prescription. It takes longer to work, around 60 minutes, but it lasts longer too. So even if parents put it on at home, it will still be effective. Both creams need to be wiped off just before the poke. If the creams cause the veins to constrict, don't worry. A warm cloth or warm pack will reverse that in 5 to 10 minutes.
So we need to get the numbing cream on the chart. To my knowledge, at the moment, the only numbing cream available is EMLA. Most other countries also have lidocaine, so hopefully soon you get this as well. The only difference is that EMLA needs to be on the child or on the adult for 60 minutes, 60, 1 hour, whereas lidocaine cream works after 30 minutes, so it's much shorter. And so far, the best data we have, if you look at the evidence, if you look at the research, the numbing cream is the single most helpful pain blocker to send up the information to the brain. Now, why would that matter? Because it's actually, so if I, sorry, what's your name?
Marie.
Marie?
Yeah.
If I'm going to hit you right now, right, really hard and give you a bruise, like, what's your pain number? Oh. So probably 8 out of 10. This looks very dangerous, right? So a strange professor from America hitting you in the second row, sort of here at the second faculty. I'm giving you a bruise. Your brain is going to say, danger, and going to be in lots of pain. Now, if you, what's your favorite sport? You soccer, basketball, Dungeons and Dragons?
Frisbee.
Frisbee. Yeah, if you not play Frisbee in the same team and I accidentally run into you and give you a bruise, you may not even notice that. So it's interesting. I'm causing the same tissue injury, a bruise. The same pain information, nociception, goes through myelinated A delta fiber into my spinal cord, crosses over at the lamina 1-2 through pain transmitters, substance P and glutamate, polarizes the second neuron, shoots up to the thalamus, there goes to my frontal brain, and you're in pain. And in one situation, I give you a bruise, your pain is 8 out of 10. And in another situation, I'm doing frisbee, I'm giving you a bruise, you don't even notice that. What's the difference?
Context. The context.
The context. It's the social context. Am I afraid of the situation or not? So even if the needle is a little bit deeper than the numbing cream, the numbing cream may only numb the first 5 millimeters and the needle is 6 millimeters, the kid's not expecting not to be in pain. If you do not expect to be in pain, you're in far less pain. So we're not recommending to do something instead like buzzy bees or shock blockers or skin cooling techniques. Kids actually don't like the cool, but you can do this on top, in addition to numbing cream, not instead. Much more information also in the New York Times for you to read. It's in your handout about the effectiveness of numbing cream and in children. As I told you, Emla cream, which you have here in the Czech Republic, and lidocaine, which you don't have yet, work equally well. The only major difference is timing. Often we heard another myth which didn't come up, was something like that we hear, oh, the numbing cream constricts the vein. So we can't cannulate, we can't do an intravenous access in because the numbing cream does that. So we have actually about 200,000 needle pokes per year. In 5 years, we did not have a single child who had some vasoconstriction. However, if you're going to have the first child tomorrow, then you can put a warm pack on and it should come back. So we found, and this is some research showing that the numbing cream will not decrease the chance of finding a vein when you do an intravenous cannulation.
But a needle poke without the pain is now possible. 11-year-old Sam Sauer agreed to show us in the emergency department.
Were you scared coming in?
Yeah.
When Sam was 4, he had to have an IV.
And it was horrible. He had to be restrained at the time.
Now the older, braver Sam is trying what's called the J-tip. It's a syringe with a small canister of pressurized carbon dioxide. It pushes lidocaine, a numbing medication, into the skin. And how quickly does this work?
30 to 60 seconds.
Then when the IV needle is put in...
Good job, buddy.
Is it done?
Yep, the needle part's all done.
Sam seemed shocked when he compared the stick to a bee sting.
This was much more better.
Kathy Walsh, CBS 4 Morning News.
So if you don't have the time for the Emla cream to wait the 60 minutes, those J-tips work within 30 seconds. They're not any better, they're only faster, and you have to get them. They're not available in the Czech Republic right now. They cost about $6 US, so about €5. For some children, some of the time, this might be the right thing. So what we hear a lot is, we just don't have the time, and we really don't want to change. There's all these important doctors who have to do the painful procedure right now. They can't wait. Can we just, Dr. Cox, is there any way that I don't want to change the workflow for my staff and I'm worried about the cost? Can we just skip applying the numbing cream? We'll just not do the numbing cream and just do the cheap and easy approach we've done in the past?
Good God in heaven, there are just so very many ways for me to say this to you. Never, not in a million years, absolutely not. No way, Jose, no chance, Lance, and yet, negatory, nah. And of course, my own personal favorite of all time, man falling off of a cliff. No! Oh, Dr. Cox.
So, no, numbing cream does not cause vasoconstriction, to the best of our knowledge. We do not have the time to wait the 60 minutes. We do, but we have to change our practice. We can't do this right now, but we have to think, okay, maybe we give the cream to the parents at home and they put the numbing cream at home before they come in for vaccination. Maybe before rounds you decide who needs a lap draw, and then you put the numbing cream on, and then you can do it 60, 70 minutes, 2 hours and from now. So we need to change how we're thinking about this, because the time, of course, is an issue. Since we have done this, waiting times went down, kids were much more satisfied, staff turnover went down, satisfaction about the hospital in general and pain specifically went much up. So it's totally worth doing it, and it can be done. It has been done in more than 50 children's hospitals in the world. So I talked about numbing cream. Let's talk about the second piece, about positioning. So this is not a great position for a blood draw.
Parents are baby's best source of comfort, so we need them to be involved, ideally by holding them. For babies under 6 months, it also helps to swaddle them. It makes them feel safe and comfortable and decreases the pain they feel with the needle. Skin-to-skin contact is another option which has been shown to increase babies' comfort. Be sure parents know how to do this before the procedure. Aw, I love babies!
Children older than 6 months feel safer and more in control if you have them sit up. It's best if parents or caregivers hold them. It depends on the age and what procedure you are doing. For vaccination, chest to chest is usually a good option. Or you could have the parent hold the child sideways on their lap with the child's legs between their parents. For lab draws or IV starts, having the child back to chest works best.
School-age kids may or may not want to sit on their parents' lap. Let them choose. Make sure you take the time to hear what they want. But remember, upright is always best.
For teens, and I can speak with good authority on this, make sure they are upright and comfortable. If they want a parent or caregiver close by or holding them, that's their choice.
To the best of our data, evidence, holding down a child for a painful procedure is never helpful. It is never helpful to the parent. It is never helpful to the child. It may be easier for us as clinicians, but we're not doing this for us, are we? So asking parents to restrain the children so that we can do a painful procedures like stitches or blood draw, that's bad medicine. We need to do this better. When we ask children, so what does it feel like when we held you down for painful procedure? The children tell us that they feel ashamed, humiliated, powerless. They tell us that they've lost the right to control their own body. So just on a quick sideline, so a few years ago, actually I was in the British Museum in London, and I looked at the Rosetta Stone. I'm very interested, I love archaeology, and I think I was always fascinated by Egyptian. And so this is the Rosetta Stone. Any one of you have seen the Rosetta Stone way in the British Museum? It's fabulous, about that big. So this is actually a stele which was inscribed by the behalf of King Ptolemaios V, 2,200 years ago. And that's me, a selfie with the Rosetta Stone. And at the top is actually this ancient Egyptian hieroglyphs, which until this moment this was found nobody could read. The middle piece is Demotic, which is everyday Greek, and the bottom one was ancient Greek. So this was actually the key to decipher Egyptian hieroglyphs. So I was fascinated. So I was watching this, I wondered, I love archaeology, and then I actually looked a bit closer. Do you know what it says? What it's talking about? Do not hold down children for painful procedures. King Ptolemaios V knew this 2,200 years ago. All right, you remember Marius? I told you this is unethical. I told you this is terrible medicine. I told you that when Marius comes back, he will need more analgesia and more anesthesia in your hospital. He's going to need more men and women power because he's afraid of us now. So how do we do this better? The one other thing you want, so on open wounds, if you do suturing, you need lead cream, which is lidocaine, epinephrine, and tetracaine. Your pharmacist can mix this, it's quite easy to do. And you apply this again for half an hour before you do sutures in. So this is my best friend's son, who was playing with my 3 children. He was going through downtown Minneapolis and then went straight into a metal pole. Huge laceration on his forehead, bleeding, bloody murder in the middle of Minneapolis. I could see the periost, I could see the skull. And so I put the bleeding child, his dad, my 3 children in, and I drove to the next emergency room at my hospital. And like any state-of-the-art hospital in the world, when you come in and the nurse thinks maybe this kid needs stitches, they put numbing cream on, the lead cream. So we waited for half an hour, his mum then came as well, and then he actually needed 12 stitches. The only thing I saw during those 12 stitches was the following. He is sitting upright. We're not holding him down. Shall we agree that he's distracted? And we numbed the skin. Why would we hold down children like Marius tonight if we can have this 95% of the time? All my handouts, all the information I just gave you, if you have any trouble falling asleep tonight, you can read them up. This is my QR code, so you can put this up. You will find the handout of those slides. I'm also going to have some articles in, and then I will share this with you, Lucy, so you will basically then share it with the faculty. So if you want to read this stuff much more up, then you have this. So there's much more information and background information and research data on the modalities I'm just talking about. Okay, so how did I present the knowledge piece here? What did I talk about? What was the knowledge piece here?
It's safe and effective to apply the anesthesia before. Well, essentially, you're wanting that it's safe and effective to apply the anesthesia to the children without overwhelming us with too much data.
Aha. Very good. So I had my one thing in the background. My one thing was what?
It's safe and effective and time saving essentially to apply the anesthesia to children before needle books.
Right. So my evil plan was put numbing cream in and don't hold them down. And then I planned everything, and now in the knowledge piece, I brought it. How did I present this? 50 slides, reading from them, or like what? How did I present the knowledge to keep you awake?
You showed both cases and evidence-based, evidence data from papers, but not going into too much detail, just to back up what you were saying.
Thank you. So I used a case, I showed some evidence. Would I have made a stronger case? There are about 83 publications about numbing cream on babies and vaccinations. Would have been more useful if I would have shown those 83 studies. Why not? That's more knowledge. Would have convinced you more? Why did I not do that? I did not present 83 studies about numbing cream. I did not present the sugar water data and the holding. Like, why not?
You wouldn't lose our attention. It's boring, so we would lose our attention.
Yeah. It's boring, and I'm going to lose your attention. How much time can I what's the maximum I can do in presenting boring stuff? A few minutes. You have to change the pace of what you're doing every 8 to 10 minutes. If you don't, nobody can pay attention. Even if the data is okay, that's good, after 10 minutes you will fall asleep. Your brain is not able to get more information. So what did I do to change the pace? What did I do every sort of 5 to 8 minutes to keep you awake?
Try
part. Be interactive with us. For example, how you did with this fear experiment.
Yeah.
So that's because of this research to different levels of study.
So interactive, right? We talked about pain nociception, that this is in the social context. That was one thing. I asked questions. Right now I'm running around, so to like this, what else did I do to keep you awake? How else did I present knowledge and kept you awake at the same time, hopefully?
You have opened up a completely different topic, for example.
You opened up a completely different topic, like the history and this whole thing, and then this like not obvious conclusion that you should not restrain children, which was just comical. Yeah, and then you made us laugh a lot.
Yeah, so that is often another mean trick, right? If you have to do embryology, right, and it's like the 17th slide and everyone is asleep, show the Rosetta Stone or something like this, and everything, then it suddenly gets quiet. I said, where's this going? Why is, what? Yeah, and then you go there, right? And then at least you have the attention for another few minutes. So that's another modality. So it's using humor, which for me is a sort of German passport holder, which of course is not naturally born. Yeah, we are well known for our singing, dancing, and telling jokes, obviously, not. So yeah, so we have to use this carefully. What else? How else did I present knowledge? Two.
You showed videos. You used a different method to share the data and your experience with the videos that you played.
I showed videos, quite a few. Why do you think I showed so many videos?
Different way for us to concentrate.
I could have said this myself. I asked 2 teenagers to give you the information. Why? It's a different way. What else?
It's personal. It's personal if we see the children.
It's personal, you see the children. It's another person. Usually if several people presenting, it's much better because it's not as boring, right? So rather than me talking, I use a lot sort of videos and use that. Again, it doesn't mean that you have to use 17 videos tomorrow in your presentation, but think about whether it may or may not make sense to do this. And I will put into my Dropbox, into the file, I will show you, like there's a detailed information how to get a video from YouTube and then put this into your Keynote or PowerPoint slide. So, slides are usually quite good, photos are pretty good. You will also see when I presented the data, it was usually bullet point per bullet point. It's not the whole slide is there, so people cannot read ahead, but it's just the first bullet point. I talk about this, and when I'm ready, then I go to the second. Videos, case, humor, and talk about, yeah, this is what I'm going to talk about. Now I'm talking about this. Thank you for listening. This is what I talked about. So have a very clear outline. So again, this is your cheat sheet. Probably the second most important thing, other than finding out why people are not doing what they want you to do, finding out why people are not doing what you want them to do, is you want them to actually learn a skill. You want them to practice something, because then it goes much more in the brain. If I tell you how to do this, it's not going to help. It's not, yeah, I need to teach you how to fish, so you fish for yourself. Giving you the fish is not going to help. So that's the skill. So let's do 2 skills, this is an interactive lecture, and the 2 things which are very effective is using cases. So I'm giving you 2 examples of a case, and then we're going to even do some role play. I'm a palliative care physician. And what I want you to do is I want you to be comfortable with giving morphine to children at end of life. I can give you a slide presentation about this for the next 3 hours and presenting all the data we have that for breathlessness, for dyspnea in children and adults at end of life, morphine is the best medication. Or I can use a case. So this is Ethan. Ethan is one of my patients I've taken care of many years ago, who was a baby who had a big heart defect. And he needed to have open heart surgery. And this is nearly 20 years ago. He had, unfortunately, significant side effects. He was on the ECMO, the extracorporeal membrane oxygenation, and he developed afterwards significant clotting. He had a clotting disorder, and he had many strokes to the point that a large part of his brain was destroyed. There were two separate neurologists who met with the family and who said, "We are afraid that Ethan will not be able to survive this. He will never be able to see. He will never be able to eat or talk. He will never be able to walk." And then I got the consult as the palliative care specialist to meet with the family. So I met with his parents. I met with his 8-year-old sister. And I asked them, "What are you hoping for? Considering what Ethan is facing, what are you hoping for?" And that we hope for a miracle, we hope for a cure. And I said, "I hope this too. I also hope that your child will be cured. What if the miracle doesn't happen?" And they said, "We do not want our child to be connected to the ventilator for the rest of his life. We do not want to have him to live a life like this." So I told them some loving families felt the best way to love their child is to have a tracheostoma, to connect them to a breathing machine and take them home on the breathing machine. And if this is what you want, we will help you to do this. Equally loving families have decided that they do not want their child to live a life like this. And they have decided then to do a compassionate extubation, which means we take the tube out, and it would mean that it's quite possible that Ethan may die within a few minutes or a few hours. They thought about this. And the next day we talked back and said, "We talked about this with the grandparents. We want a compassionate extubation." I said, "But only if you can promise me that Ethan is going to be comfortable." I said, "Okay, I promise. I will be in the room to get palliative care as an extra layer of care." So this is something I discussed with the intensive care doctors, the cardiac intensive care doctors and team at the time. And he already was on a morphine infusion. Actually, it was fentanyl, same thing, Coke or Pepsi. He was itching on morphine, so we switched him over to fentanyl infusion. He also was in a benzodiazepine, on midazolam infusion, to keep him calm enough. And then the moment came when we took the tube out. He was not breathing above the ventilator, so we assumed that he's going to die very quickly. Like many babies, I've done this for 20 years now, they decide not to do what we think they're doing, and Ethan decided not to die. In fact, he was actually doing all right. However, he was very breathless. He was gasping for air, and he seemed very uncomfortable with the breathing. As a pain specialist, as a palliative care specialist, we know, of course, that the best thing to give is morphine, or fentanyl, or oxycodone, or methadone, whatever opioid you have. And so he was basically on a PCA, on a system, so he had the infusion of the fentanyl, and I could push a button and give him doses of the fentanyl. The same with the midazolam. And he needed quite a bit, and I had to increase the dose. 1 hour later, he was on 3 times as much fentanyl than before. He was on nearly 4 times as much midazolam than before. And then he was comfortable, breathing. I was not killing the child. I was helping to make him really comfortable. In fact, the family said, "Okay, let's go outside." Ethan has never been outside. And basically, you see the PCA machines with the midazolam and fentanyl in the background. We spent a few hours outside. And the next day, the family said, "We want to go home." He did not have a feeding tube there at the time, so they did feeding to comfort, which means not feeding through a feeding tube, but just as much as he tolerated. He got some morphine under the tongue for breathlessness and in pain, and the family took him home. And exactly 4 weeks later, on the day, the family had a picnic at Minnehaha Falls in Minneapolis, and Ethan died, comfortably in his parents' arms. The family allowed me to share this. We were actually going to put this into the New York Times, so you're welcome to read more details about this. And the point of the story is children at end of life, adults at end of life, will live longer and better with morphine. You will not kill them. All right, I used a case. Why? What was my one thing in that case?
It's emotional.
It was emotional, but what was the one thing? What was the clinical background that I presented this case? What did I want you to learn about this case?
Using morphine would help with dyspnea. Using morphine would help with dyspnea, giving the patients an easier exit.
Thank you. Morphine helps for dyspnea. And you do not kill them. It's not euthanasia. But that's like, even today in 2024, many people are very afraid. Oh my God, I'm going to kill that baby. I'm going to kill that grandmother if I give some morphine. And we're not, no, they actually live longer and better. So I could have chosen to show you the data. There are lots of studies out there showing that this is safe. Why did I do this? Why did I choose a case instead of showing the research data with you?
It's a real life example. It's a real life example.
It's a real life example. This is somebody I saw, somebody I met. And this is probably something you're going to remember. If you ever take care of a patient at end of life, whether it's grandmother or it's a baby, you might remember Ethan. And you might remember that, in fact, giving pretty good doses of morphine does not kill them. So this is the use of a case. So you can use your own patients, pictures if the family allows it. If they don't allow it, you can do just a Google picture, right? Or you do something like this, and you change the name, you change the age, so make it sure that nobody knows this. But that's, using a case is a very effective way of teaching. Let's give you a second example of using a case. Okay, you're working in the children's hospital. It's 3 o'clock in the morning. Liam is coming into the emergency room. He's a 10-year-old child in severe pain. Maybe it's an osteosarcoma. Maybe it's a sickle cell crisis. Maybe he has a pancreatitis. Maybe he has chemotherapy and now it's mucositis. So severe pain, something you will not be able to fix tonight. He's going to be in the same pain tomorrow. He weighs 20 kilograms, no allergies, no effects, normal renal function. You don't have a PCA at the moment. And you basically want to give him an opioid, a strong pain medication to give him. So we think about morphine, or fentanyl, or oxycodone, or something like this, unless there's a good reason not to. So how much morphine do you give him right now? He weighs 20 kilograms. He's in pain right now. He needs some morphine. Yeah. So here's your poll. He's screaming. You have 30 seconds to answer, right? He's in pain right now. You have to tell how much morphine he's getting. IV means intravenously. PO means by mouth. Yeah, how much morphine would you give? Yeah. And once you've voted for a dose, you can click on results and you can see what people are answering. All right. How do we give the morphine to Liam? What are my ways? How can I give morphine? Where are the clinicians? How do I get morphine into this child? IV, intravenously, by mouth. Which one is better? It depends. We ask the patient. Liam, you're in severe pain right now. I can give you some intravenous morphine. However, we would have to give you an IV line for this, or you can swallow a tablet or liquid. What would you prefer? Give choices. At 3 o'clock in the morning, you may not be able to get an IV access, even if IV intravenous is faster. So ask the patient. And then when you write the order, even those of you who say a psychology student at the moment, this is not rocket science. This is not rocket surgery, right? Here's the dose. He weighs 20 kilograms. This is the dose for intravenous morphine. This is the dose for oral morphine. A range means a small child with small pain starts at the lower end. A big child with big pain starts at the higher end. What's a Liam? Is he a small kid with small pain or a big child with big pain? He's a big kid with big pain, so we start on the higher end. All right, I'll give you 1 minute. Please talk to your friend next door. Please do the math and give me a morphine dose. How much morphine would you give Liam right now at 3 o'clock in the morning? "20 kilograms. He's still screaming. He's in pain. No pressure. All right. 0.1 milligrams per kilo times 20. That's 2 milligrams of IV morphine right now. You can schedule this every 4 hours. If he doesn't want to get the intravenous morphine, you give him oral morphine. Either liquid or a tablet, or you can swallow even the intravenous. You give 3 times as much. So it will be 6 milligrams every 4 hours. You also do a rescue dose, a breakthrough dose, which is 10% of the total normal dose. Okay. So this was my second case example. Liam is not real. I'm a pain specialist. I've taken care of kids in pain for the last 20 years, so I've seen many children like Liam. Why did I use this case? What was my goal in teaching here? What was my one thing?
Decision making. Decision making.
Decision making. And even more concrete, what was my one question?
What would you do personally?
What would you do? I even forced you more. I said, yeah, we want to give morphine. What did I want you to do exactly?
To decide.
How much? Yeah.
How much and in which form?
The teaching point was here, how much morphine should a child with 20 kilograms get? I just could have shown you the slide. I forced you by, at 3 o'clock, he's under pressure, right? He's screaming, you have some time right now. Here's the data. What did I ask you to do?
It's like a real situation decision?
It's a real situation, and what did you do? You actually calculated, right? Hopefully. Maybe to say, I'm a nursing psychologist student, I don't have to do that. Yeah, but hopefully you calculate this. The fact that you calculated 0.1 times 20 makes 2 milligrams will increase the chance that tomorrow, if you ever have to prescribe morphine, that you remember this by about 50 times. Me just talking about this, you're sleeping away, so not doing this. Now I was doing a skill. I invited you to do the math. So you always, if you want to do people something differently, give them a chance to practice, to do something with words or with numbers or something like this. It very much increases the chance that they learn this and they will apply this. All right, the last thing, which I see very effective, and usually is the least favorite thing, is role play. Role play is basically, so let's just say, Adam was diagnosed with bone cancer 7 months ago. He has struggled with side effects of chemotherapy, and he has missed quite a bit of school and his favorite soccer practice. So Adam is now coming into the clinic today with both parents, Natalie and Rick, to learn about the results of his routine follow-up scan.
Hi, Adam. Rick, Natalie. Adam, your parents tell me you want to be more involved with your care and treatment as we go forward. And I just want you to know I respect how you've been coping with your treatment and tests.
So, what do the tests show?
As we talked about on Thursday when you were in for the imaging results and lab work, our hope was that the IV chemotherapy and radiation would stop or slow the sarcoma. I'm sorry to say the results are not what we hoped for. the mass in your upper leg is still actively growing. CAT scans detected metastases, which is cancer growth tissue in your abdomen and both of your lungs, which is why you've developed that cough.
So the chemo and the radiation didn't do anything? Well, you said that most of the time that this treatment works. Why wouldn't it work for Adam? Are you sure the results are right?
In many situations, this treatment plan has been effective in stopping the cancer from growing, but it's not completely effective. And it's not effective in everyone. Even at the top dosing levels that we were safely able to deliver, this treatment plan is not effective in stopping Adam's cancer.
So when we think about this, we can think about what went well in this role play. These are actors just playing this. We can also talk as what can we do better. So how do we define a role play? It's a drama in which a number of participants are asked to portray a particular character, but no lines are learned. Or another definition, so why would you use role plays? We can help to practice some sentences. We can practice difficult language. I can show you slides forever. This will not make you more comfortable in doing a difficult conversation tomorrow. It's really very much about, I can talk about chocolate all day long. You have to eat the chocolate to understand chocolate. So when you want to teach students or doctors how to facilitate a difficult conversation, something like, the cancer has come back, you will die. There's no way for me showing you a slide. The only way you can practice this is either in front of patients or in a role play. Yeah? So you want to teach things and want to make it safe. You have much more information. I put like an extra 80 slides in my handout for you to read about how we facilitate role plays, how do we save, how do we do it in a way that the participants like it. And you always want to make sure that one thing happens to the other. So a very simple example, very safe, is like a paired role play. So what I would like you to do right now, please, is just go together in groups of 2. One of you is the doctor, who basically says, who breaks the bad news. The other one is the mother or the father. Yeah? The doctor just says, I have difficult news to share. Adam's cancer has unfortunately come back and we will be no longer able to cure it. Or in Czech.
Mám pro vás závažné zprávy. Adamův nádor se vrátil a už nebudeme schopni ho vyléčit.
And then mom or father are going to give some emotional support. Something like this. Oh no, like how dare you, something like this. And then we use silence. We wait until mom is looking at me again. Because they're going to be like this, and then suddenly they're going to look at you again. And then you say, I cannot imagine what this might be for you. What this might be like for you.
Neumím si představit, čím procházíš.
And then you use silence. So I invite you, you don't have to, but I invite you, because we're teaching how to teach, just practice this one thing. If you go to back in groups of 2, one is the doctor, one is the mother or the father, and just use in English or Czech sort of those sentences, use the silence, and then we come back and I just will ask 1 or 2 of you how that was. All right. So this is a paired role play. I do not know what you're talking about. 1 or 2 feedback, how was that? Scary, useful, amazing, terrible? Thank you for volunteering, this is great. How was it for the 2 of you?
I was the patient. I have never been the patient, so it was a bit weird for me. It was a new experience.
It wasn't totally new for me because we were role-playing with my student before, but it's always personal. When you try it and you experience it, it's different procedure than when you only listen to the talking and to the presentation.
So would you prefer to practice this in front of the patient? Or would you prefer to practice this in a safe place?
I would prefer to have this discussion always in advance and to train it before we talk to the patient.
We can talk about the chocolate. We have to eat it. Certain things you cannot teach through a PowerPoint slide. Certain communication pieces, like breaking bad news, the only way to do is that people use sentences like this. And the only other way to do is you do it with patients. And that may be not the best way to practice. But you can use this out, thinking, okay, stop, that actually didn't work. How about I use this, use that? So using role play in very sort of quick things, you practice 1 or 2 things, not 30 minutes role play, terrible thing, everyone is hating this. But keeping it really short, yeah, is something. So paired is what you just did. You can do it an observer, you can say, okay, 1, 2, 3, 1, 2, 3, 1 is the doctor, 2 is the mother, 3 you're an observer. You're looking at them and then teach them, like, tell me what happened. That is something you do with a big group. A fishbowl is actually, okay, 3 people are coming up, we're not doing this, yeah? Let's just play this here and everyone can look, yeah? So you need to have some comfort. If you start with this, after 10 minutes, people are hating it, right? So so you need to be comfortable with this. You can use a video case. You saw me showing a video of this, of Adam, right? And that's something you can then use and discuss this. What did she do well? Like, how would you do this better? That is a great face. This is amazing. I love that. Let's do this, yeah? Would you say this? Okay, you play Adam, you play the mother. So you can, in a discussion, try out 1 sentence or 2 sentences to do this. The best is, of course, is to having a standardized patient. So this is, are you using guys standardized patient? So standardized patient is an actor who comes in, who plays Adam or plays a patient, and you just practice with this actor breaking bad news. And then you stop, you get feedback, it's videotaped, yeah, and that is another very effective way to teach sort of sentences. All right. Think about your next lecture. In the next 12 months, you're going to use a PowerPoint presentation unless you're going to teach. What is the one thing you want people to do differently? What's the one thing you're going to cover? Any ideas? Who knows already one thing they're going to do next time? Shout it out.
I would use oh God. So the presentation which I'll have soon will be the presentation about the preventive care cancer prevention in the middle school. And I think I will use the strong hook in the beginning to get this kids' attention, because I think like the first 5 minutes of the presentation really mean a lot more than the rest of the presentation, because if you don't get this attention in the beginning, you lost it completely, and there is no way of getting it back. So I will use a really strong hook.
So you're going to use the hook. What is the one thing? So you have middle school student listening to you about preventive cancer care. What do you want them to do differently tomorrow after the talk? What's the one thing?
It will not be like young kids, so teenagers, and I want to teach them about the importance of HPV vaccination and quitting smoking if they smoke or not smoking at all.
All right. So that is the one thing, right? At the end of the day, you want to do something, and you hope that all of them get an HPV vaccination, boys and girls, right? So you talk about this, yeah? Thank you for having me. Yeah, after this video you just saw, what I'm going to talk about is, I think, why it's really important to get HPV vaccination. Okay, let's talk about this. Thank you so much for listening. It was great. I hope I could convince you to have this. Put everything about the one thing. Don't do too much stuff around there. And your lecture will be so much more effective, and you will, if you want to change behavior. And by the way, stop smoking. Yeah? All right. We're finishing up, right? We're at the top of the hour, so we have 50 seconds. When we think about skill, right, you can do a case example, you can do small, large group work, you practice something. You saw me using a skill like Liam, you had to do the math, right? That's a skill. I asked you to think about what could be the one thing you're going to do in the next lecture. I could ask you to write this down, talk about this. These would all be a skill. So again, in your handouts, you have your cheat sheet, and you need to practice. The more often you do this, obviously, the better you get. You want to make sure that you're walking around, if you can, if you dare to do this. Change the pace every 8 to 10 minutes. Ask people, write it down. Go back to, yes, that was great what you mentioned before. Use visuals, pictures, videos, if you can. And since it's an interactive lecture, invite the participants' participation. How many times did I ask for your feedback? A lot, yeah. I don't know, 15 times maybe, that I went forth and back and asked you things. That becomes an interactive lecture for that matter. So moving, tone and volume. And again, not everyone is as comfortable in walking around and doing, extrovert. You might be very quiet, and that's fine as well. Everyone has a different style. But you can still move a little, you can still look at people. And looking at people is actually really important because you get their attention, plus it's less likely that they're going to use their phone. And especially if you're using your phone, then I may come closer and then until it becomes uncomfortable. So you can use that as well. Know your stuff. Make sure you know the AV, like the microphone is working. Be prepared to answer questions, use humor, and be prepared for challenging participants. There's more information about this, like what do you do if you have really difficult people in the audience. Do not read to the audience. It makes it boring. And then practice. All right, bus groups, we talked about this. So finishing up with Fluffy. Fluffy, I have this presentation next week. When I just click through all my 58 PowerPoint slides, will this improve pain and symptom management for my patients? So Fluffy seems very effective then do so. So when you design your lecture, think about the one thing. Think about the hook. What is the attitude, the obstacles, the myths, the barriers? Would people stop you from doing? Address this. Do the knowledge piece, do it shorter, and then do this basically the skill. And make it very interactive. All right. We're nearly done. So teach back to me. What surprised you? You've all been in thousands of presentations. You heard the title of this. What did you not expect? What was the new thing you got out of here today?
Actually, the one thing that you talked about in the beginning, in the middle, and in the end. I think that I never heard that before.
So to conceptualize, if you want to change behavior, the one thing. Again, if you have to cover all of physiology, like respiratory physiology, for medical or nursing students for do the test, there's more than one thing. So then it's really learn well, or good luck, or But then at least you can make it interesting. Okay, what else? Other things which surprised you, which you did not think you would hear today.
And then the change of the speed is good to do every 8 to 10 minutes, so I was very surprised that it's so short.
So using the pace, right? Doing something different after 5 slides, 6 slides, do a video, go around, do a question. You've seen you can use interactive lecture, and you can do like a poll, right? Use the QR code, people are answering. So do something different. Make a bus group, okay, like the two of you, like everyone just go together and for the next 2 minutes talk about this, right? So there are many ways to interrupt the lectures and make it more interesting. What else? What else did you hear you did not expect today?
Maybe I can. What I found interesting was that usually we give our conclusions to the listeners, but what interested me that you draw a conclusion from us, so we can recapitulate. Right. This is what I learned.
And it's so much more effective, right? What I'm doing right now is I do my conclusion slide, right? I showed you my conclusion slide. You already have forgotten it. But by now asking around, you're saying, okay, let's see what was have happened, right? And 10 people left, right? They have to look for patients, or they have waiting, the coffee is waiting, right? But at least you sat here, right? And it might be really helpful or not to think about this. And me asking you this right now will improve the chance that you're going to remember this in a month. Okay, 1 or 2 more things and then we're done. I promise. We will shall be done in 45 seconds. On this side, 1 or 2. Thank you. Okay.
Actually, I think what I will take for my next lecture is your end. Not only letting the audience to ask you questions, but you asking the audience what you actually are taking home from here.
This is a great point, thank you. This idea, oh, I'm the professor, I'm the full vessel, and you're like the empty bucket, and I come in and I'm going to spill my knowledge into your empty bucket, and then you, after 523 slides, your bucket will be full. That's rubbish. Many of you may be really good teachers, you may know the concept really well, and things better than I do. That's okay, I don't feel threatened by this, and the only way is to ask. I said, that's a good point, I hadn't thought of that. This is really important. What else, though?
I like the idea of addressing the barriers at the beginning of the talk.
Thank you. So this is absolutely key. If the goal is to change the behavior, you want pulmonologists to give morphine to patients at the end of life. You can talk about the data until the cows come. They're not going to give morphine tomorrow. If you show basically, okay, what would be the problem? They're going to die. I give them morphine dose, this patient is going to die, I don't want this. So you have to address this. Okay, let's look at the research, they're actually not dying. If you give morphine to children or people who, like in this audience, they're going to stop breathing. But if you're breathless, they don't do that. So why is that? So you have to explain this, but first you have to get the barriers. Oh, I don't know the dose. The reason I'm not giving this, I don't know how much morphine I should give to this grandmother who's 99 years old who's breathless. Then let's practice this, right? Rather than Liam, who's 10 years old, let's do Teresa, who's 99 years old, who weighs 45 kilograms. How much morphine would we give her? So if you don't explore the barriers, why would people not do it? Then you have very little chance to do that. All right, lovely people. Thank you so much for having me here at the second faculty. I will stick around for a few more minutes if you have any questions. Other than that, have a great Tuesday, and until next time, bye-bye.